Good evening, everybody, and welcome to this Lipi Care series of webinars. So this is the first of a group of webinars that will be that's organized by Sanofi and endorsed by Emirates Cardiac Society. And it will focus on the management of dyslipidemia and the gaps that we have in the knowledge of dyslipidemia. I'm sure you've heard a lot about dyslipidemia over the time, but despite hearing a lot, we still see that there is a gap in it, as you're going to hear in the talks that we're going to have today and the talks that you heard before. So it's always important to keep reminding ourselves of the guidelines, reminding ourselves of the importance of this topic and how to manage it properly. So just a few housekeeping remarks. So this webinar is CME accredited. In order to get the CME points, you will need to answer the survey at the end of this webinar. So please answer the survey and the questions posted at the end, because we're going to use this to plan the future webinars for dyslipidemia. So your feedback is very, very important to us. So today we're starting with Professor Abdallah Shahab. I'm sure he needs no introduction. He's an excellent educator. He's been working in the field of internal medicine, cardiology, and interventional cardiology for the past 25 years. And he has lots and lots of publications. It's always a nice surprise to read one of his articles. And he's going to be talking to us first about, do we still need to invest in dyslipidemia management? And then we're going to hear from Dr. Antoine about the management of a very high risk and high risk patients. So again, a reminder, don't forget, post your questions in the question link so we can answer them immediately. And I'll give the floor to Dr. Abdallah Shahab for his talk for tonight. You're on mute, Dr. Abdallah.
Thank you very much, Dr. Juwairiya, our Vice President of American Cardiac Society. I call her a superwoman, actually, behind all us to be active, stay active all the time. So in this, I think I try to make it very brief. I cannot speak for 40 minutes. I think it's too long. So together we're going to discuss what's the status of dyslipidemia in the region. And these are my decoration. And whatever I'm going to say is my opinion. So objective of this, look at the prevalence and the leading risk factors for ASCVD, and then discuss the dyslipidemia association and challenges its management, I think, together with my colleague Antoine. So this slides you see all the time. This is to remind us that, although we're living in the COVID time, almost like 4 million died of COVID by more than a year and a half. 17 million dies, and that was 2015. Nowadays, also, they say about 20 million dies of the cardiovascular disease. So every 34 people dying every 60 seconds. So they're giving me 40 minutes to talk. That means more than what? 1,600 want to die. So I try to reduce my talk to save more life. These are the components of cardiovascular disease: are ischemic heart disease, ischemic stroke, peripheral vascular disease, or arterial diseases. And just to take you on what's happening in our field in the Middle East. These are publications. You can see Alawi here. We have Dr. Rasadi. We have lots of Zakwani. All lots of our friends here. Done lots of. We collected all these together. We looked at all the studies. 200,000. Subjects who can say at risk of having CVDs. We look at them and we found the prevalence of vascular disease is, look at here, 10 point compared to the world. World is 4%. So we are more than 2 times. This is the latest. This is a 2021 publication. And just in a moment, I'll tell you, if you look at this individual, you find different prevalence, but this is collecting all together. So it varies from 7 to 14, so it's average 10, very high. And the leading risk factors You can see here dyslipidemia, it's at a range of 43%. And then we have hypertension, of course. Then we have diabetes. So 1 and 2 in Emirates, we can say, this is Middle East. 1 and 2 in Emirates maybe have dyslipidemia, and some region 1 and 1. Very bad. طبعا in Emirat, if you look last 10 years, there's increase in these risk factors by 50%. So ischemic heart disease used to be second 10 years ago, now is high. But look at the risk factors here. Look, these are risk factors. Sorry, I think I missed it. These are risk factors like high blood pressure, dyslipidemia, fasting, glucose, tobacco, the behavior things. Okay, so we know that cardiovascular disease is the leading cause of death. We know the risk factors. Let us go to the clinic and see, discuss together how we can, see our practice. Then I'll bring you back to what's happening in UAE. So we take an example here. 60 years old, a smoker, of course, lots of people smoke here, young age. Patient had a primary PCI, that means opening the artery mechanically for inferior MI on the ECG, see inferior changes. So in the right time, that's good things to do immediately, but on long-term, patient needs to prevent readmission, attack of heart attack or other cardiovascular events. Need to do something else, not just putting a stent. So it's coming to us after 6 weeks. Normally they come back after 3 months, sometimes 6 months because we forget them. But this is a kind of ideal case. Patient already discharged on rosuvastatin, okay, 40 milligram. I mean, you can say 80 milligram atorvastatin, equivalent. Aspirin, ticagrelor, these are the current management of the patient with the coronary artery disease or acute coronary artery disease. Again, beta blocker, these are standard, and ACE inhibitors. So patient on discharge, you can see the LDL was, that means the patient when he had MI, so LDL was around 112. So after 6 weeks, it went to 994. How much reduction is that? It's not 50%, isn't it? I mean, we agree, it's not 50%. So what's the reason for that? Is it this the problem? Is it rosuvastatin, 40 milligram? Or is the patient not taking the medication? Or the patient is maybe non-responder? We don't know. There are many reasons. And unfortunately, maybe in this patient I know, but let me just also take you to what we've done and look at all the acute coronary syndrome in the Middle East. Again, we as a pool, we collected that, is about to be published soon, inshallah. Again, you can see here the association, the risk factors for these people to have acute coronary syndrome. You can see dyslipidemia is there. Again, range from 32 to 47. Dyslipidemia means there are many reasons and many definitions for it. It could be in diabetic, could be almost like normal, but they have low HDL, a high triglyceride, that dyslipidemia, and again, and as you know, the values changes all the time. Let me take you to the acute coronary syndrome patients of Emiratis who are having MI. Then we looked at their files, and we see what's our practice, not just looking at the ideal Dr. Juwairiya practice or Dr. Bawan. We look at everyone, we look here, and we found a patient who had MI, surprisingly, their LDL were 84. This is Emiratis, huh? So we think everyone LDL must be very high. That's when they have MI. No, they had, like you can say, it's normal. But that's not the surprise. The surprise is what? Look at this. When they come back in 6 months, this is an average, some of them 78. So what's the problem? Although they were discharged on, at least you can say here, statin, they were on a statin of 40 milligram of either rosuvastatin or atorvastatin. So what's the problem? We don't know. Here we don't know. It could be many reasons. Could be patient not taking the medication, and this is the common thing. Patient not adherent, patient side effects of it, patient not able to afford. I mean, Emirati cannot say that afford. They must be afforded, but they don't like take medication. That's the reason. Then we looked at and this is looking at the multi-center prospective hospital-based cohort study on efficacy of very simple medication. This is kind of designed. We look at the patient, okay, look, that one, we've done a survey, we not looked at we didn't tell the physician what to do. Here we say to the physician, You educate, you need to, make sure you take the lipid profile, everything, and, do things properly. And here we looked at the real statin, which is of intermediate, or you can say moderate intensity, not like atorvastatin or rosuvastatin. So to tell you, when you take a medication, a bit of education, you can do a good job. You can see here, these patients, we had different categories, high risk, intermediate, and low risk. In general, you can see good reduction. Although this is called pitavastatin, it's like a very simple kind of statin. You see 42 reduction compared to what we saw on that acute coronary syndrome, like 10% reduction. So it's not the medication itself. It needs a bit of education, a bit of interest from physician, a bit of adherence from the patient, and a proper follow-up. So many things goes on. So then we looked at, if you look at the Gulf, so we did, CFIUS is from Gulf. I was a senior author on this one. And this tells you, again, 48% of patients in Gulf region do not achieve their lipid target. That's in general. That's everyone, not just like every. And dialysis, this is our colleague Wael Mahmoud was in this one, and you can see 68. This is a more kind of risky patients, not reaching their goal. So we are doing maybe great job in primary prevention, which where they don't get much events, but in secondary prevention we are not doing great job. And the reason for that is easy to blame other things. Oh, because you have family history, because of hypertension, because of multi-risk factors. It's very difficult to focus, and so many reasons. Always you find excuses, but that's true. Dyslipidemia will not happen in isolation. Always with other risk factors. But let's just go back to what's happening in the lumen. It's LDL. All the evidence I'm going to show you comes from here. There are under investigation remnants and LPA is coming but in addition to inflammation, in addition to thrombosis. So it's not just LDL. Many multifactorial. All these 5. Of course, our discussion today on LDL, maybe future, inshallah, LPA, but not to forget when you come to approaching patient, everything, all these 5 at least. So why LDL is important? Genetically, those who have genetically, inherited problem with LDL receptors not there, they have, early myocardial infarction in their family at younger age. And that's from genetically. And from prospective and from randomized clinical trial, when we target LDL, the outcome is always, advantage. There is improvement in reduction myocardial infarction and the rest. And if we're able to do that, if you can convert that patient to somebody with lots of LDL receptors, that means you are removing their PCSK9, for example, you are basically improving their outcome. And that could be done by statin, which are a main medication. We have statin. And you can do that with ezetimibe, although maybe it takes longer time to get the benefit. Together, even much better. PCSK9, as I said, this is a new invention in the field of lipid management discovered. And when you have that means if you have inhibiting that, you have more LDL receptors, that more absorption, pickup of the LDL from the circulation. So reduction of that. So you can see by any means you do that. By statin, ezetimibe, PCSK9, and the other, you will get the benefit. Relative reduction as well as absolute reduction. So not anymore we say, we have to do LDL by statin itself. There are many ways to do that. And that's only important. It's important also the duration. So we don't want to give medication for a patient for a day or 2 or 1 week or 1 month or 2 months. This is long life. To do something on long term, that medication should be really, you can say, is simple, easy, and patient able to afford it. And then we learn that, not, as I said, there are primary prevention, the secondary prevention. There are low risk, moderate risk, high risk, very high risk. The more high, patient the risk is higher, the lower you want to bring their LDL. And of course, that's not happening in the real life, to be honest. I mean, we saw from our registries. But that's the case. That's what the guidelines say. The higher the risk, the lower we need to bring the LDL to get the benefit. How low it is, the lower the better, as long patient able to tolerate. And there are some cases mentioned and been published, even their LDL 0. But it will not affect the brain, of course, because there are different circulation there. So the other thing is, in addition to that, monotherapy itself, as you can maybe later on, or my colleague Antoine will mention, if you come to the statin, the problem with the statin is, in general, okay, the mean is you can get up to 50% reduction. That's the mean. But individual, we're dealing with individual. That individual varies. That might not get 50, might get 0, or might get 100%, or might get 40 or 30. We don't know. How to know that? Inshallah, one day with artificial intelligence, we're able to do that. But for now, you need to do lots of homework, to invest your time with the patient to know exactly is going to respond, and patient will not get side effects, because some people, you give medication, and instead of getting the benefit, they get the side effects of it. So what's happened in the randomized clinical trial and the publication, it's just the mean, and the mean you will not get it on the individual person. You always get something different, and not only that. So you need something to maintain. So you want to keep the patient on that target and to maintain that for a long time, and not that swinging. Swinging is not good as well. So fundamental principle in LDL lowering is all trials showed a relative and absolute reduction in LDL is important to get the outcome. And we are aiming for very high risk, those who have had MI, with diabetes, with renal problem, all these together, collected together. These are very high risk. The LDL need to be less than 55, less than 35. And again, you cannot, this is population. Individual, you might go even lower, because when they might start at their LDL when they had MI, maybe 60, maybe 50. You have to go lower. And this is the problem. This is what we need to do as a together. It's nice to always discover new medication. This is every day you hear a new medication coming to the market. That's fine, but the more medication, the less adherence. And this is from evidence. The more pills, the less adherence. How to simplify, and maybe you can bring 2, 3 medication, 1 tablet, 1 pill. That's great, and that's available nowadays. We've seen it in the past. Simvastatin with ezetimibe, then came atorvastatin with ezetimibe, and now we have rosuvastatin with ezetimibe. So instead of starting 1 medication and then add another one, if it's very high risk, start 2 together. And that's in what way you do 2 things. You are reducing the side effects, you're improving the adherence. So these are the reason patient stopping, or the burden of patient adherence. Patient age, maybe forget, so too many medication. I have a friend who already had MI, unfortunately, and then we bought him this box, where he put the tablets. And despite of that, he forgets. Imagine, this is a young person. The more comorbidities patient have, the more side effects from the medication fractions. Number of medications, for frequency. Sometimes that's medication twice a day, that's once a day. This is not easy. And of course, the lack of efficacy, the patient. So I'm not gonna, that's what I'm saying. Investing time with the patient on first visit is very important to improve the adherence. So high intensity, and then with a good adherence from the patient. So you start something, the medication with you're aiming with the good bullet you go with, and with adherence patients you get the best outcome. Of course, the vice versa is true. To conclude, so we've learned together the prevention of cardiovascular risk factor is crucial, and we've seen in the Middle East is 2 times what's happened in the world. And we've seen the leading risk factors, and LDL or dyslipidemia is the major role player. And we found together that statin, which we had it for a long time, is the mainstay of treatment of patients with ASCVD and familial hyperlipidemia. And there are many of them available, and they're generic available as well. So, and we learned today from one case, and I showed you multiple cases from the published recently on acute coronary syndrome from UAE, that nearly half of our acute coronary syndrome patients fail to get below their guidelines recommended target goal. So who to be blamed? Ourselves, patient, medication. I think we have to take all that into consideration and then try to tailor it for our patient. Many patients treated with a statin are unable to achieve and maintain. So that's the problem. It's not just achieving a goal, it's to maintain it. You know, we've seen that. That's what we need to do. That. How to do that? Simplify the medication. Can make 2 tablets, 3 tablets in one pill. Adjunctive therapies, this is what I said, is ezetimibe here, should be from beginning, if you can simplify it. PCSK9 is available. You know, and the patients, of course, to understand about the mechanism of the things you give and the side effects from beginning is also very important. So a strategy that facilitate adherence is important. There are many. I mean, this is, I cannot think for you. I mean, we need to, you know your patient in front of you, you know what sort of patient he is or she is. There are many ways to do that through the listing time, flyers, this kind of education we do together for physicians. We may be able to gather and come to some kind of improving our patients' outcome. So thank you very much.
Thank you, Dr. Abdullah. Very comprehensive talk. There was actually a question related directly, and we're going to have the discussion at the end, but I thought the question is related directly to what you presented. So it was about the study that you showed in the for the Emiratis of how they were not controlled post-ACS. They were asking, was this in a specific Emara or it was all over the UAE? And was it only Emiratis or was it mixed? Like, was it in the UAE but with mixed originality? Yani some of them are Indians or some of them are Emiratis.
Yeah. So this is the first study, Doctor. Thank you very much for that question. I think very important. This published already on Heart Views is available online. It's first studies on Emiratis, and this is from the Sahha facilities. All Sahha, Abu Dhabi, Al Ain, all the facilities. Around 5,000 patients, Emiratis. And the reason we selected Emiratis because we said, okay, there's no excuse about the medication. You can give any medication and we'll put them on the right medication. But now the problem, we don't know because what we did, we went through their files. It's a retrospective, it's not a prospective. We went through the files and we look at the documentation. I mean, of course, we found a lot of shortcoming from our end. Documentation not right. Why not discharge on 40 or not 80? Why some patient not discharged on statin at all? Nothing mentioned. So this is Dr. Juwairi, what I'm trying to say is, when you design a study, it's very easy to get the perfection. But when you look at what our practice, something else.
You find surprises, huh? Not pleasant surprises, but surprises.
No.
Okay. So we'll move to Dr. Antoine. So Dr. Antoine is a consultant endocrinologist at Imperial College of London of Medicine at Tulane University of New Orleans, USA. And he's American board certified. So he's going to talk to us about the management of very high risk and high risk patients. So go ahead, Dr. Antoine. Again, you're on mute.
Yeah, thank you, Dr. Juwairi, Dr. Abdullah. Thank you, everybody, for having me this evening. It's going to be a bit longer talk than Dr. Abdullah's presentation. We're going to go through several studies. We're going to try to make it easy and simple. We're not going to go into all details of numbers, just to make it more interesting and see how we can apply the information in our daily practice. Now, the importance is, the important question, does reduction in LDL cholesterol lower the risk of major vascular events? There was a meta-analysis from the cholesterol treatment trialist collaboration in 2012. There was a study designed just to group about 134,000 patients and in 5 trials of more versus less statin. And they were looking at the major vascular events, like major coronary events, strokes, or coronary revascularizations. Participants were separated into 5 categories of baseline 5-year major vascular event risk on control therapy. The results were the following: that the reduction of LDL with statins reduced the risk of major vascular events. The proportional reduction in the major vascular events was at least as big into the 2 lowest risk categories as in the higher risk categories, reflecting significant reduction in the 2 lowest risk categories in major coronary events and coronary vascularization. There was no evidence that reduction of LDL with statin increased the risk or incidence of cancer or cancer mortality, and so on. So if you look at this scheme here, that you can see that each 1 millimole reduction in LDL produced an absolute reduction in major vascular events of about 11 per 1,000 over 5 years. So these are the categories. They were just developed: less than 5%, 5 to 10, 10 to 20, 20 to 30, and more than 30%. So this will take us to the role. We're going to concentrate in this presentation this evening on the rosuvastatin and rosuvastatin with ezetimibe. So this is what we'll be covering, so you have an idea ahead up what we're going to see next. There was a study in 2003, the Stellar trial. So this was a 6-week parallel group, open label, randomized, multi-center trial conducted in 182 United States clinical centers. 2,431 adults with high cholesterol randomized to treatment with rosuvastatin, atorvastatin, pravastatin, and simvastatin. A 6-week across-dose analysis showed that rosuvastatin 10 to 80 milligram reduced LDL by a mean of 8.2% more than atorvastatin 10-80, and 26% more than pravastatin 10 to 40, and 12 to 18% more than simvastatin 10 to 80 milligram. Reduction in LDL was significantly lower when treated with rosuvastatin. So this would show us that rosuvastatin in a way is stronger than the others. In Jupiter trial, this was a different kind of study because it was assessing the impact on cardiovascular event and adverse event of attaining LDL levels less than 50 with rosuvastatin in apparently healthy adults. So the Jupiter was really involving otherwise healthy adults, and they were given the rosuvastatin. About 17,802 apparently healthy men and women with high sensitivity CRP, more than 2, and LDL less than 130, were randomly allocated to rosuvastatin or placebo. The primary endpoint was to see if there was any development of MI, stroke, arterial revascularization, unstable angina, or confirmed death from cardiovascular causes. The results was really astonishing. Rosuvastatin allocated participant achieving LDL less than 50 had lower risk of cardiovascular event. In what? In apparently healthy adults. Rates of myalgia, muscle weakness, neuromuscular condition, and so on, they were not significantly different among rosuvastatin allocated participants. The conclusion was that among adults with LDL less than 130, remember this patient who have LDL less than 130 and apparently healthy, rosuvastatin in participants attaining LDL less than 50 had a lower risk of cardiovascular events without a systematic increase in reported adverse events. So this was Stellar, and this is Jupiter. And now we're going to move to Saturn trial in 2011. This one was, the objective was to compare the effect of atorvastatin or rosuvastatin on the progression of coronary arteriosclerosis, as well as their safety and side effects profiles. The study design was a prospective study, randomized, multicenter, double-blinded, serial intravascular ultrasonography in 1,039 patients with coronary artery disease. The primary endpoint was change in percentage atheroma volume. The study results safety and efficacy. The rosuvastatin resulted in reduced LDL levels and higher level of HDL. And the rosuvastatin was associated with significant regression of coronary arteriosclerosis with a few adverse events. So what about the benefit of adding ezetimibe to rosuvastatin? There was an Explorer trial in Ballantyne in 2007. The objective of the study was to investigate the efficacy and safety of rosuvastatin alone or in combination with ezetimibe in patients at high risk of coronary heart disease. A 6-week trial, open label, randomized, 469 patients were randomly assigned to rosuvastatin 40 alone or in combination with ezetimibe for 6 weeks. The primary endpoint, percentage of patients achieving the adult treatment panel 3 LDL goal of less than 100 at week 6. The results were the combination of rosuvastatin, as you can see, the combination in green. The combination of rosuvastatin and ezetimibe reduced LDL significantly more than rosuvastatin as monotherapy. Both treatments were well tolerated, and frequency of liver and muscle and renal adverse events were low in both groups. This will take us to another study. I know we're just telling you just briefly of each one, the summary of each one of them, so that's why you have a good background of the studies and what they've shown so far. In the Improve It was Cannon et al. 2015. They did a randomized active control double-blind study involving patients who had been hospitalized for an acute coronary syndrome, designed to evaluate the clinical benefits of ezetimibe simvastatin combination 10-40 milligram compared with simvastatin monotherapy 40 milligram. So one group received simvastatin 40 and the other group ezetimibe simvastatin 10-40, and they will follow up visit day every 4 months. Duration minimum of 2.5 years follow up, and the primary endpoint they were looking at the cardiovascular death, coronary revascularization, or non-fatal stroke. So the median LDL level was 53 milligram and 69 milligram with simvastatin, ezetimibe, and simvastatin monotherapy, respectively. So the median LDL level was higher in the simvastatin monotherapy alone. At 1 year, levels of total cholesterol, triglyceride, non-HDL, ApoB, and CRP were significantly lower in the simvastatin ezetimibe group than in the simvastatin monotherapy group. The event rate for primary endpoint was 32.7% in the simvastatin ezetimibe compared with 34.7% in the simvastatin monotherapy group. The conclusion was the addition of ezetimibe to statin therapy resulted in the reduction of LDL level by approximately 24%. Combination of ezetimibe and simvastatin also resulted with a significant reduction in the cardiovascular risk. So what was the efficacy and safety of ezetimibe rosuvastatin combination? So if we do the ezetimibe rosuvastatin combination, is it safe and how efficacious? The Kim and et al. In 2018, they did a multi-center randomized double-blind phase 3 clinical trial to compare the efficacy and safety of ezetimibe and rosuvastatin combination therapy with those of rosuvastatin alone in patients with primary hypercholesterolemia. The study was a run-in period of a placebo for 4 weeks, and then during the screening period, patient discontinued any other lipid-lowering medication, underwent a washout period of 4 weeks, and then a placebo run-in period of 4 weeks. The baseline lipid measurement were taken within a week of visit 3. For the main study, patients were randomized to a study control group and given medication for 8 weeks with a study visit during week 4 and week 8. And as you can see, in the main study, the group 1, and they had rosuvastatin 5 and ezetimibe 10, then rosuvastatin 5 and ezetimibe placebo, rosuvastatin 10 and 10, rosuvastatin 10 and the placebo, rosuvastatin 20 and ezetimibe 10, and rosuvastatin 20 and the placebo. And this is the end of treatment 1. And then if they were taking the combination, they remain on it. If they were taking the rosuvastatin and the placebo, the ezetimibe was added. The same thing applies to the other 2 groups. So the result after 8 weeks of treatment, ezetimibe and rosuvastatin combination therapy lowered the LDL levels significantly more than rosuvastatin monotherapy, as expected. The pooled data analysis showed that ezetimibe rosuvastatin combination reduced LDL level by 56%, whereas the reduction of LDL level with rosuvastatin monotherapy was 45%. There was also significant improvement in total cholesterol, non-HDL cholesterol levels with the combination. The combination therapy was also shown to be efficacious in patients with diabetes mellitus. High percentage of patients attained their LDL goals using ezetimibe combination than those on rosuvastatin monotherapy. The percentage of patients who achieved their LDL goal at week 8 was higher among those receiving the combination compared to the one who received the monotherapy. 94 versus 86%. The same was observed in each subgroup of varying rosuvastatin doses. In particular, the combination of ezetimibe 10 and rosuvastatin 5 showed greater efficacy than rosuvastatin monotherapy. So in terms of adverse event, there was no serious adverse event, no occurrence of similar receiving combination or monotherapy. The adverse events were more frequently reported in patients receiving combination versus rosuvastatin monotherapy, particularly with Rosova 10, ezetimibe 10 combination than with rosuvastatin 10 milligram alone. The most common or the most frequently reported adverse event were increased ALT, increased AST levels, and nasopharyngitis. So in conclusion, the combination showed efficacy that was maintained for an extended period, allowed more patients to achieve their LDL goals, and led to additional benefit changes, including patients who has responded well to rosuvastatin monotherapy, and it was generally well tolerated. If we switch gear to another study, it's kind of all in a way given us the final information as expected, but it would be nice just to give you a quick overview of all the studies that really involve mostly the rosuvastatin and ezetimibe, so let's have a good support of knowledge that we can use. So multi-center randomized double-blind active comparator tried to compare the efficacy and safety of ezetimibe and rosuvastatin combination therapy with those with rosuvastatin alone in Korean patients with high cholesterol. So a run-in period of 4 weeks, the treatment period for 8 weeks, patient that received ezetimibe, rosuvastatin, or rosuvastatin monotherapy, or they used a lower dose of ezetimibe 10, but lower dose of rosuvastatin 10 and rosuvastatin 10 as monotherapy. And then the third one was 10, 5, and 5 alone. And they were followed. And then after that period, they were seen if they were just receiving the rosuvastatin 20, and then they were 10 was added, and so on to make all the group similar. After 8 weeks treatment, there was a follow-up period for patients who had achieved their LDL goal. Those who had previously received only rosuvastatin were additionally given 10 milligram ezetimibe, whereas others continued to receive ezetimibe and rosuvastatin combination therapy. So after this 8 weeks of treatment, the efficacy of each dose was superior to the corresponding dose of rosuvastatin monotherapy. So the combination was superior. The mean percentage change in LDL receiving the combination was more than 50%. The pooled data analysis showed that combination therapy reduced LDL by 57%, whereas the reduction in LDL with rosuvastatin monotherapy was only 44%. So treatment with the combination of ezetimibe, rosuvastatin reduced LDL level more than rosuvastatin monotherapy by a statistically significant difference of minus 12.6 in milligram. A higher percentage of patients attained their LDL goals using the combination than those on monotherapy. The pooled data analysis showed that the percentage of patients who achieve LDL at week 8 was significantly greater among those who received the combination. So the combination therapy was also shown to be more efficacious in patients with coronary artery disease or a 10-year cardiovascular risk indicated by Framingham's score of more than 20%. So it was good for the patient, even the high-risk patients. So the percentage changes in total cholesterol, triglyceride, non-HDL, ApoB levels were greater with the combination therapy than with rosuvastatin monotherapy. And there was no significant difference in the overall incidence of adverse event. The most common adverse event were gastrointestinal disorder, laboratory findings, including liver function test results and creatine kinase levels, were comparable between the patients group. In conclusion, the combination therapy significantly lowered the LDL, lowered mean by the LDL by more than 50%, helped significantly more patients to achieve their LDL goals compared with rosuvastatin monotherapy, and was safe and very well tolerated. And the author suggested that fixed dose single pill combination of ezetimibe and rosuvastatin may have the additional benefit of improving patient adherence, as Professor Abdullah mentioned earlier. So combination and single pill combination is always, almost always better than 2 or 3 different separate pills. So how does the addition of ezetimibe to rosuvastatin compare with the uptitration of rosuvastatin? So the case here is when you start rosuvastatin and then you have not really reached the goal and then you add ezetimibe. Is it, the progression or the sequential addition of another agent? Is it better than the uptitration, or if you give, just a combination from the beginning? So the ACT study from Bayes et al. In 2011, that was a study, randomized, multi-center, double-blind, comparing the efficacy and safety of ezetimibe 10 milligram added to stable rosuvastatin therapy with uptitration of rosuvastatin from 5 to 10 or from 10 to 20. So as probably you already guessed, so the combination from the beginning, it's better, in terms of the outcome and so on. So the patient about 18 to 79-year-old with high cholesterol and moderately high risk or high risk without aortic valve disease or high risk with aortic valve disease. Moderately high risk patient or at least 2 risk factor. So you're all familiar with the high risk and very high risk patients. But in this particular study, the high risk without AVD patient, and then we have another group of high risk with aortic valve disease, and they were just treated and they were followed. In the study, as you can see, there was a 4-week, 5 weeks for those switching medication or they were treatment naive. They gave them rosuvastatin 5 milligram, and then after the double-blind treatment period for 6 weeks, so they added the ezetimibe. Either they get ezetimibe 10 with rosuvastatin 5, or they received the rosuvastatin 10 milligram, and the other group received 10 milligram rosuvastatin, and then they were just receiving either ezetimibe 10, rosuvastatin 10, or they increased the rosuvastatin to 20 milligram. So these are 2 groups in stratum 1 and stratum 2, and I'm going to show you here that the people really received the combination from the beginning, had a better LDL lowering effect in both stratum group compared to the up titration. So the combination from the beginning is better because you can hit 2 in 1 as first. So the percentage reduction in LDL levels achieved by adding ezetimibe to rosuvastatin was significantly higher than attained by up titrating rosuvastatin. Target LDL for patient without aortic valve disease was less than 100, whereas target for LDL in patient with AVD was less than 70. A significantly high percentage of patients achieved their prospective LDL levels with rosuvastatin and ezetimibe add-on than with up titration of rosuvastatin. So analysis of each rosuvastatin run in stratum yielded similar results. So the results, regardless of the risk status, pooled data analysis showed significantly more patients who received rosuvastatin plus ezetimibe achieved LDL less than 70 than those who received a double rosuvastatin dose. So giving the combination is stronger than increasing gradually the rosuvastatin dose. Analysis of each rosuvastatin run in stratum yielded similar results. Patient receiving rosuvastatin plus ezetimibe add-on therapy showed significantly higher reduction in total cholesterol, non-HDL cholesterol, and ApoB. And there was no serious drug-related adverse event observed. So the fixed dose combination, what about the efficacy and safety? As the previous studies have mentioned, it's kind of pretty much, even though different studies and different objectives and design, but the endpoint is really leading us almost to the same kind of findings. So in this multi-center randomized study, Mrs. Rose of rosuvastatin and ezetimibe is a multi-center randomized double-blinded. The objective was to compare the efficacy and safety of fixed dose combination of ezetimibe 10 milligram and rosuvastatin with the rosuvastatin alone in patients with primary hypercholesterolemia. And you can see all the groups received combination 10-20 or 20 alone, 10 and rosuvastatin 10 alone, and 10-5 and rosuvastatin 5. And they were randomized for 8 weeks. And the results were that the combination fixed dose lowered LDL significantly more than rosuvastatin monotherapy. Ezetimibe rosuvastatin combination therapy achieved significantly greater reduction in LDL levels than rosuvastatin monotherapy. In the pooled analysis, reduction of LDL level combination therapy was about 59% and 49% in the other monotherapy group. So if you can see here, the rosuvastatin 20 plus ezetimibe was the strongest in terms of reduction of the LDL cholesterol, and ezetimibe combination compared to monotherapy 20, you can see it's about 9 difference. So it's really the combination was really better than the rosuvastatin alone in each and every single group. So in the results, the combination was more significant in terms of lowering effect of LDL, and among the high-risk patients, with CHD or CHD risk equivalent or a 10-year risk more than 20%, more patients receiving ezetimibe and rosuvastatin combination therapy achieved their LDL targets than those receiving rosuvastatin monotherapy. There was no report of adverse event, as we mentioned. The incidence of muscle, liver, hepatitis-related, and gastrointestinal-related and allergic reactions was generally low and similar between the two treatment groups. So in conclusion, fixed dose combination is really better than the monotherapy alone. This will lead us, I know we have covered many studies showing the oral agents of ezetimibe, rosuvastatin, or rosuvastatin alone, and so on. This will cover all the oral therapy that we use. Now, if we switch gear to the injectable one, I'm not going to go into so much details in the Odyssey outcome, but just a few slides. I'm going to just to talk a little bit about the PCSK9 inhibitor, alirocumab. And the Odyssey study is a very interesting study that patients with recent acute coronary syndrome on maximally tolerated statin, more or less of other lipid-lowering therapy, not at a predefined target, LDL was more than 70, or non-HDL more than 100, or ApoB more than 80. And then they were divided in two groups, 9,000 each. One group received the placebo subcutaneously every 2 weeks, and the other group received the alirocumab 70 milligram or 150 milligram every 2 weeks, adjusted in a blinded fashion to achieve less LDL between 15 and 50 milligram per deciliter. And so the main inclusion criteria was patients older than 40-year-old. They had ACS relatively recently, 1 to 12 months prior to randomization, acute MI or unstable angina. They were on a high-intensity statin, atorvastatin 40 to 80 daily, or rosuvastatin 20 to 40 daily, or maximum tolerated dose of one of these agents for more than 2 weeks. Inadequate control of lipids, LDL still above 70, non-HDL above 100, and ApoB more than 80. And there was exclusion criteria. It's a long list, as you can see, that uncontrolled hypertension, they have stage 3 or 4 heart failure, or ejection fraction of less than 25%, the history of hemorrhagic stroke, if fasting triglyceride is more than 400 milligram, use of fibrates other than fenofibrates or fenofluoric acid, recurrent ACS within 2 weeks, and coronary pervascularization performed within 2 weeks prior to randomization. If you have liver enzyme elevated 3 times the normal, if you have creatine kinase more than 3 times the normal, or if you have a GFR of less than 30, and obviously if you have a positive pregnancy test. So the primary outcome to see what have the time to a first occurrence of coronary heart disease death, or non-fatal MI, or fatal or non-fatal ischemic stroke, or unstable angina requiring hospitalization. So all the outcome adjudicated by the Clinical Events Committee, and members were unaware of treatment assignment and lipid levels. The major secondary efficacy endpoint tested the coronary heart events, major coronary heart disease event, cardiovascular event, all-cause death, cardiovascular death, and all cause of death. So to make long story short, they were just randomized in two groups. One received the placebo every 2 weeks, and the one received the alirocumab subcutaneous every 2 weeks. Patient and investigator remained blinded to the treatment and lipid level for the entire duration of the study. And we're trying to keep the ratio between LDL between 15 and 50 of LDL. So if it is above 70, they're considered as undesirably high baseline range. And all analysis conducted by independent academic statistical team. And about, as I said, about 18,000 patients. They were divided into two groups. The premature treatment discontinuation, about 1,343 in the alirocumab group, and 1,496 in the placebo group. The blind switch to placebo was 730 in the alirocumab group, and patients lost to follow-up because of vital status, which is 14 in the alirocumab group. So the baseline patient, they were diabetic, hypertensive, smoker, the female about 25% in the group, and the age, average age about 58. And those people, they had acute coronary syndrome, 1 to 12 months prior to this study. So they had a different type of, ST elevation, ST, with MI, unstable angina, and so on. And their LDL level, as we mentioned, they were just as above acceptable range in those people at very high risk and already have acute coronary syndrome. In each group, they were receiving, as we mentioned, a high dose atorvastatin or rosuvastatin, or receiving atorvastatin, ezetimibe with or without statin, and no lipid lowering therapy in only about 0.9%. Those people are cardiac patients, so they were receiving, aspirin, P2 wave antagonist, ACE inhibitor, ARB, beta blocker. And this will be lead us to the findings of this study. In the placebo group, you can see there was no further LDL reduction, whereas in the alirocumab group, you can see within the first few weeks, you can see the improvement and the lowering effect of more than 50% of the LDL. That you can see in the first few weeks, as I said, and this reduction was really maintained relatively after almost 1 year. So with the 1 year, 2 years, 3 years, and you see for 48 months. So this was really a very persistent effect of the alirocumab on the LDL reduction. As you can see, so the placebo, there was really not much of a further effect on the LDL lowering, but in the alirocumab group, you can see a very significant reduction, and that was really relatively maintained, even though it was lower in the beginning and kind of fade a bit away, but still very significantly lower than the placebo group at 48 months. So as you can see, the primary efficacy endpoint in MACE was lower in the alirocumab group with a p-value of 0.0003, was very statistically significant. In terms of all cause of death, was lower in the alirocumab group with a p-value of 0.026. And this Odyssey outcome, all-cause mortality, as you can see, in all causes, the red for alirocumab group was lower, was better, and cardiovascular event was lower, and a non-even cardiovascular event was just even lower in the alirocumab group. As you can see here, all the parameters in all areas, they were in favor of alirocumab group versus the placebo. So this was really better in this group in all terms of LDL, in the region, or in the sex, or in age, in all aspects. So all-cause mortality and LDL level and the outcome, so they were really all better in the alirocumab group. So among patients with ACS and baseline LDL more than 100, alirocumab reduced MACE by 24% and all-cause death by 29% compared with placebo. And just to summarize that the combination of rosuvastatin with ezetimibe has proven to be more efficacious and safe than the rosuvastatin as monotherapy. And in cases when you have a very, very high-risk patient and not able to reach the target, then a PCSK9 inhibitor like alirocumab can be considered and to be used in order to reach the target, in order to lower the LDL and to prevent and to reduce all-cause mortality, MI, and so on. And thank you very much for your attention. Thank you very much.
Thank you, Dr. Antoine. That was very extensive and a very excellent review. So we have a couple of questions from the audience, and I would encourage the audience to keep posting the questions so we can address them. So the first question, the LDL is 1.3, which is 50 millimole, and the patient has premature IHD. Should you aim for lower? What do you think, Dr. Abdullah?
Excellent question. I think this is what we learned. Actually, we'll keep learning. I mean, there are many reasons, Doctora, as you know, is causing, if a person is young and his cholesterol is as low as that, we need to look at other reasons for the, it's not LDL itself, it's LPA, as they say, it's a small one. I need to look for that remnant, we look for it. The other reason, it's not just LDL. That's what I said at the beginning. We have to be very, but because talk today about dyslipidemia, so having premature acute coronary syndrome, per guidelines, say you need to bring it lower, at least 50%. So as again, that individual able to tolerate the medication, afford the medication, stay on the medication. These are important things.
Mm-hmm. So they have to go 50% lower, so at least 25, less than 25, with all the medications that we have. I mean, then that can be achieved. So random question, I think, Dr. Abdullah, because he talked about the risk factors. So someone is asking about e-cigarette smoking. Can it carry similar risk?
Yeah, Dr.
e-cigarette, so this just came me.
Remember, Dr. Juwari, we had a talk on this actually a long time ago, and we don't know really. I mean, if you look at the literatures, it depends which one you look. It says similar, some of says less. It's a kind of if the person is aiming to stop smoking, then that's fine to start with. But if it's going to be a substitute, or not right. Long term, we'll go back to smoking again.
Plus, also, it's not a regulated
exactly.
industry, so we don't know exactly what's in this cigarette, so we cannot really say. So, Dr. Antoine, do you come across familial hyperlipidemia patients in your practice?
Yes, I do, but it's not as common as we think. We think we read more about it than we really truly we see it in our daily practice. Even though we see too many patients in our center, but the real familial, the homozygotic one, I have maybe 2 patients only because they really run in families. So usually those people, they will be screened and be followed by a certain, maybe sometimes certain clinic. But the heterozygotic one, yes, we do see, we have cholesterol like, in milligram, let's say 600, 700, 800, we do have those patients. But the real homozygotic one that, we see like in thousands, honestly, surprisingly, I would say, in our busy place that we don't really face too many. So we don't have too many as we, according to our practice. Now, remember, now in our practice, outpatient. So a patient, get really sick or they get really all this acute coronary syndrome. Usually they may they go to hospital and be followed by a hospital. So relatively speaking, patients, they come to us relatively healthy. even the complication of diabetes, like diabetic foot and so on, we do have, but it's not as we did see, let's say, like what I saw like in the United States, years back, was amazing. Now here, thanks God that we don't really get to see so many very sick people, because maybe of the treatment awareness and the education, and patients that become really so much aware of the disease and so on. They take good care of themselves now, and especially with the new generation. So really, to answer your question, I don't see too many of the real true familial hypercholesterolemia.
You see a couple, Dr. Abdullah?
Well, Doctora, we did recently a Gulf FH study, which was published recently in +4 or +5, I don't know whatever journal it's called. It's a very nice journal anyway. So it's looking at the 5 countries and the region, about, I think, 34,000 patients screened, and 3,713 suspected FH. That gives you a 0.9% of familial in our region. That means 3-fold higher than the world. So we might see them and we don't recognize them, Doctora. Yeah.
True.
So what was the definition that you used in the study? Was it a very high LDL, more than 190?
Yeah, and the definition, the one which, I can't remember them from my background, but it's the one already published in the per guidelines. I mean, this is the absolute one, and then the probable one, and so they went according to that. Then genetics, of course, and the study is going on to look at that as well.
Okay, nice. So the next question is about familial hypercholesteremia in pregnant ladies. So how would you treat that?
Very difficult, huh?
Yeah.
Well, in pregnancy, obviously, you cannot just use a statin, and usually we left them untreated. If really, in case really that when you have a severe, and then you may consider the external extracorporeal plasmapheresis and so on. But honestly, that's something that we don't get to see. I haven't had any case. I've been here now 14 years in Imperial. I haven't heard of even one case that we had to do something like that. Not only with my patient, even within my colleagues. So thanks God that we don't get to see those. But we cannot use statin. So period. So this is no question. So we cannot just take a risk. And remember, now I would take the advantage of asking this good question for the audience. That we would rather, if somebody not already diagnosed with hyperlipidemia, please do not do a lipid profile in a pregnant woman. If somebody is not diagnosed with hyperlipidemia, do not do just screening hyperlipidemia in pregnancy, because pregnancy by itself per se is going to increase the numbers and going to make you and the patient anxious and so nervous about it, and that's nothing you can do. Unless somebody's really being treated and being followed, then you have to follow this to make sure you're not really missing a major event that can really affect the pregnancy itself or the fetus. So just I want to take the opportunity again one more time. If somebody's not diagnosed with hyperlipidemia before, do not ask for a routine screening lipid profile in a pregnant woman.
Yeah, Doctor, I remember, I don't know, about 10 years ago, I had a patient who had familial hyperlipidemia. I'm not sure, because this patient tells me, so she was actually pregnant, and she came to us with the STEMI, and we tried to be, very cautious, not to use the, radiation too much, because all that, and we kind of cleaned the artery, just ballooned it, because not to put at that time before the evidence for DCB was not there, so we just ballooned it, and we just to make sure the patient will survive. And because even you don't know about the Plavix, there are many reasons, you don't know what to do with this patient. So statin, of course, we cannot use, and we knew because the lipids will not be. We need something long term, not just for short term. And we said, okay, until the patient, delivered, and this. So it's a challenging. You don't have medication to help you at the acute stage, but it's not only statin. There are other medications. It's difficult to use in pregnancy.
It's true. It's a difficult situation. Yeah. So if you don't reach the target, even with the powerful medication that you have, what do you do? So you are on a statin, high dose, ezetimibe. So so they didn't mention what medication, but I assume they think PCSK9 as well, because Now it's available and everybody has it. So if you have the three, statin, ezetimibe, and PCSK9, and you do not reach the targets.
Yeah. You need to ask yourself, ask the patient, what's happening? Are you taking the medication? That's the problem. Because as I said, doctor, I cannot believe that everyone in Emiratis, not responder to statin. Because, those I said to you, they were coming 88, their LDL, and only just went down to 78. So what happened? Something wrong. And really, if you dig into it, you find out, that the people don't take medication. Yes. And that's why we need to, as a physician, you need to be really think about, be in shoes of the patient. Think, this is very difficult. On long term, it's very difficult. If you're able to simplify it, beautiful. Start from beginning. So you don't want to say, okay, I'll start you with a statin. Then I'll start I will not do that. And all my patients, this is what my practice. I know. And in the past, I used to say this. Now, evidence going toward that. And say, start the combination together. Why you have to go stage 1, stage 2, stage 3? No, start together. Then if not, patient not entire, then you can use PCSK9.
Okay, it's a question about in CKD patient, is it safe? I think that's Dr. Antoine in relation to PCSK9 inhibitor. So that question came during your talk. So is it safe in CKD patients?
Yes. Yes, it's safe. You can use it. You may adjust the dose. You may go, for example, like in this one, like 75, twice a day instead, twice a week, twice a month, every 2 weeks instead of 150 every 2 weeks. You may consider lowering the dose, but you can still use it. Yes.
Okay, very good. So this is, I think it's an important question because we always, when we talk about the high-risk patients. We know this stuff. When you lower is better, high-risk patients, it's very easy. Give them all the medication. But this is actually primary prevention question. So in the primary prevention, so they're asking what's the LDL cut point for primary prevention to start double therapy. So to start a statin plus ezetimibe. And do you need to calculate the 10-year cardiac risk? So what are your thoughts? Dr. Abdullah, maybe first, and then Dr.
Right. Primary prevention, remember that familial hyperlipidemia is primary prevention. Okay, here you don't need to do the risk score. You just start double. I told you. And just remember, people more think this is primary prevention. Now, then you come to the real primary prevention, which is the everyone. You need to do the risk stratification. Again, the problem is not with which score to use. We looked at the many scores and again published, and really we don't know which one is suitable for us. We don't know. I mean, we are trying to look at the data which is published in Waqaya just to find out maybe we'll come with a new score for our region. But these are helpful. These risk score helpful, but you cannot say it's absolute. You need to use our brain, of course, and we need to see the patient. Again, at the end of the day, doctor, you want to get the benefit. You need to treat 1,000, with that statin for long term to get the certain benefit. But again, you don't know if that patient is going to be among those who are going to benefit or going to get the side effects. Lots of thinking going behind that. It's not that easy as that. As a population, yes. If I'm a government, I say, okay, I'll give this to everyone, khalas. But that individual is not population, it's individual. I need to go to the patient's shoes and to see adherence issues, side effect issues, availability, many things. Lifestyle is good.
Yeah. Now, for the risk, actually, it depends really. What you can do is everybody knows if you have a very low risk, you're fine. If you have very high risk, it's fine. Now, where really patient, when they fall in between, if you have, let's say, somebody's a 55-year-old, healthy, otherwise, his cholesterol LDL is, let's say, 135. Or in millimole, let's say 3.2 or 3.4 or something. So what would you do? So if the cardiovascular risk, calculated risk is, let's say, if 7.5, what would you do? So that's the problem. So people are really high, above 10%, less than 10%, less than 5% or so, you're probably okay. So these people in between, they're not diabetic. They're coming to you for a second opinion. Should I really take some statin? There's nobody really in the family, no heart attack. So what would you do? So for those people like middle age and you're not really sure, it's the best thing, the recommendation how to do is you do a calcium score. And you can send them for a calcium score, and you will see if the score is normal, 0, then you can just skip for now and you follow up. If the calcium score is high, then you have to treat them, or with the discussion with the patient, and you decide together what is the best. So really, calcium score can help you in cases in between. So low risk is fine. High risk, we all know. So the people are really in the gray zone where you really face, what to do with those people. So you can maybe do a calcium score. It's non-invasive, easy, available in the UAE, in many places, in Abu Dhabi, and everywhere. So that's something that can really help you a little bit to take a final decision about it.
And that's true, Dr. Antoine. But yeah, I think where I and Dr. Abdullah come is that our low risk are not really low risk. So this is our problem. Because, this is what you said is the guidelines. But the problem is if you catch some of the MI patients and you calculate the risk before they had the MI, they were actually low risk. So this becomes the problem here. And as Dr. Abdullah said, our risk scores, they don't work. The international risk score, they don't work for us.
Yeah, I want to say what Dr. Antoine mentioned. Actually, this is what tools we're going to use to improve. It's away from risk score. What tools we're going to use to improve our tailoring therapy for our patient. I think CT calcium, possibly, and CT coronary angio also very helpful. You're speaking about individual. If you go into the population, it's very difficult, very expensive. It's not that easy. So that patient who come to you with the LDL is high. Okay, and the patient, if you look at the risk score, is just, and he's not convinced. So, doctor, I will not take medication. So I will try my lifestyle, whatever. And you do a calcium score, and there's lots of calcification there. And this, you say, okay, no, you have calcification. I'm not going to improve that calcification, but I'm going to prevent something else happening. And I say, no, if you're not going to improve that, you go into lots of argument with the patient. But then the patient, because actually you're giving a statin to this patient, you're going to increase the calcification. This is also the statin is increase the calcification of coronaries. It's not that easy, and it's wallahi, what says in the guidelines is helpful, but primary prevention always difficult, except the familial hyperlipidemia. But secondary is because they already had event.
So it's easy. You just get them.
Hammer already in their head, they will listen to you.
Yeah, I recently, I had a patient, so I saw him when he was 40 years old or 41 years old for hypertension. So he doesn't have coronary disease. His lipids were a little bit high, and calculated the risk, and the risk was low. So I did not treat him. And then I saw him, now he's 42, and his cousin had an MI at age 40. So now, so now it's the same lipids, but now I treat them.
Yes.
So it's a tricky question. You cannot just. It's very difficult. Honestly, it's very difficult. So I guess risks help you, but then you have to look into other things as well, and how much you can convince the patient to go on therapy as well. That's another.
Exactly.
So someone shared with us a case. So this doctor encountered a familial hyperlipidemia patient who got pregnant and then developed pancreatitis. And the pancreatitis was treated. So they eliminated the pregnancy. And so now they're asking what kind of therapy to do for her now. Can they do plasmapheresis for her? Well, I guess the pregnancy is terminated. So if it is terminated, then she can go on the therapy, on all the therapies, yeah.
Exactly.
So she can go back on her regular therapies. Anyone want to add something?
So what's the reason of pancreatitis?
Because of a hypercholesteremia.
Okay.
Maybe high triglyceridemia, because usually hypercholesteremia may not be probably high triglyceride, I meant.
Yeah.
Okay. So another question, or actually maybe clarifying a previous question. So a patient not achieving LDL goal, what is non-HDL goal and very high and high, moderate, and low? They're asking about non-HDL goal. When to use a non-HDL goal? Yeah,
you see the problem. I think we all agree that diabetes is in our region, is especially the Middle East. Meta-analysis we did, we were higher than anywhere else. And using just LDL itself will not convince you to say, oh, look, I'm in the goal, but really they're at risk if you do the non-HDL. You do non-HDL, they find that they are more than 30. So if LDL is supposed to be for that patient 70, and then the non-HDL should be 100, less than 100. So that's why. But when you do in diabetic, you will find the LDL may be at the goal, but non-HDL is higher. So that's why you need to intensify your statin. Not to be happy, but okay, patient at LDL at the goal, khalas. No, that's not right. You need to do non-HDL on that. That's the best way to do nowadays. That will help you, as Dr. Antoine says. Here need to intensify your lipid lowering by adding another one, or combine it together, or maybe even go for PCSK9, especially in diabetic patient.
What about lipoprotein A? When would you test for lipoprotein A?
And when I write paper, I don't know, Antoine, when is
Yeah, practically speaking, honestly, I don't really know. ApoB, there are times when I think, it's feasible, but LP little a, as I said, in academic and in paper and publication is important, but in real practice, up till now, I don't think we have a really, special use for it in terms of therapy, because it's not going to change your management. So management is going to be decided on the LDL, on the non-HDL level, and so on, and the overall condition. So until now, there's no real specific medication for the LP little a per se. So really, it's not going to change anything in your management. So I think a waste of time and maybe a waste of money if you really you want to just do it only to decide on a therapy. But it's good if you're doing a study and you see the efficacy of the certain medication and new products, new molecule. Yes, definitely, because this will lead us in the future to maybe certain news. But for now, it's not going to change anything in your management.
So how about the elderly patients above 80 years old with high LDL? Do you treat, and how do you treat?
You treat, but don't have to be very aggressive, because what is the life outcome is what we're gonna make in 20 years. So it's already 80. You treat and you accept a reasonable numbers as long as they're safe and no side effects, no interaction with other medication. Then you treat. Yeah, I do treat them as I normally do, but without being no heroic, measures.
Yeah, I agree with you. If you look at if you're a trialist, they say. We all agree that when you have very high risk, age is the main risk. The older you are, the higher risk you are. So if you want to get the most benefit, you get at the higher risk. But again, how long? The problem is if you are very old, you have very high risk, but the benefit again needs duration, a longer time. But that's why they say there's no much studied here, but they put them at very high risk. You will get absolute benefit, but again, absolute benefit needs some time. And that time is the problem at the elderly. They will have all the side effects from is really multiple, their side effects. That's why Dr. Antoine says, again, you have to tailor it. Always, that's why we are physicians. That's the art of being a physician, is to tailor things, to personalize.
As I always say, I agree. Guidelines only to help us, to guide us, not to dictate our decision, because at the end you are with the patient and you think what is the best for your patient, rather than just going by the guidelines just to dictate your life in treating diabetes, hypertension, dyslipidemia, and so on. Our guidelines only guidelines. The name is guidelines. It's not something that to. So the art of medicine is really to decide what you think is the best and to use the common sense. That's why AI will never replace doctors.
Good to hear. Okay. Antoine, how about very high triglyceride related to type 1 diabetes? So how would you treat that?
Okay, this is, usually it's not a common thing that you have a type 1 with high triglyceride, because unless the triglyceride is a familial hypertriglyceridemia, then you treat it as you normally do, as with all the, fibrates that you use or any other low triglyceride, medication. But as I said, again, a type 1 is not typically accompanied by a high triglyceride. High triglyceride is mostly in, type 2 and insulin resistance syndrome and so on. Unless somebody, bad luck, get the type 1 from whatever, and then the triglyceride from the family. So it may happen theoretically, but I don't think it's a very common situation. But you treat it as you normally do, as high triglyceride with fibric acid or gemfibrozil, whatever you think is the best.
Yeah, Dr. Antoine, maybe use this time since you are the pathologist and you guys look at the eyes. We don't look at the eyes and the retinopathy and the link of triglycerides with the retinal problem. Is that something you encounter nowadays? You try to treat the triglycerides to improve that? I mean, is that something?
No, have to be really real, one of those type that you have high chylomicrons and very high LDL, but typically chylomicrons, lipoprotein lipase deficiency. These are become real rare events that you see or you face. When I was in the lipid clinic long time ago, we used to see them because it was a tertiary care at Tulane, and we have trained people from all over the state to come to a lipid clinic. Yes, but in a regular practice like we are now in general, like diabetes, and really we don't get to see those patients. Honestly, we don't. I always ask myself, where are these people? Why don't have a high triglyceride of like 3,000 and 4,000? I don't get to see them here. The highest I've seen here at Imperial, maybe I would say in triglyceride, maybe 2,000, 1,500, that's it. Maybe 2,000 something. I've never seen that 6,000, 7,000, I don't get to. Good, we don't, but so triglyceride is something that you have to deal with, and going back to your question, or to somebody's question, type 1. So type 1 and triglyceride is not a very common combination, but if it happens, you treat it as you normally do.
Okay, I guess someone wants to hear again about calcium score. So there's another question about the role of calcium score in primary prevention with the statin. So, yeah, go ahead. Dr. Abdullah, you're on mute.
Sorry. Calcium scoring. So what exactly the person wants to understand?
Do you want to know about the role of calcium scoring in primary prevention use? Like how will you use it in primary prevention to decide on statin or not?
Yeah, you have a number, it's below 10, below 100, between 100 and 400, above 400 calcium scoring. That tells you the patient, preclinical, then, what level of preclinical. If it's less than 100, you try to modify the risk factors, and you convince the patient, look, you need to lower your lipids. The lipids, whatever you have, is not good for you. You need to reduce it. But we have a means to do that. I mean, that's why I use calcium scoring to help me to convince because patient wants to see something objectively. You speak to them like just subjectively. You might something happen to you in future, doctor. You say to once they know their brother or their neighborhood, but something to see in their heart, they'll be convinced to take it. So I use calcium score as a way of conversation opening, to say, look at your, this is where you need to use the medication. Here's the important medication. But again, to know where the categories, if it's between really 100 and 400 is at intermediate, below 100 is very low, but less than 10 and 0 is good. 0 is good. But again, you need to look at other risk factors. So that's why I use the calcium score.
Yeah, so for that doctor who's asking this question, actually the same in the scenario I gave you earlier, this is where you have somebody you feel like, they have high little bit LDL, but no other really major risk factors, so they're not really at very high risk. And they're, resisting the idea of taking medication. And that's where you can do the calcium score because the risk is not very high. So you need to, if you do that, as Dr. Abdullah said, you can show them something really tangible. You can see, okay, look, you have calcification now. So your decision will be you're taking your own, you're at your own risk. I recommend that you take, statin now, and I think that's the best way to do it. If you don't want to take it, but at least you do have calcification. I think when you show a patient you do have some calcification, a high score or medium high score, then I think they will take the medicine.
I think it's also very helpful in patients who are, risk calculators will show that they are low risk, but that they have a modifier. So, like for instance, like for women, for example, premature menopause is one of the modifiers. Someone with, I wouldn't say family history because family history is important and you treat that patient just forget about calcium score, treat that patient. But like, premature menopause, obesity, these things, they don't come into the risk calculators and they increase the patient risk. So if you do a calcium score and you get it 0, then you feel more comfortable. Okay, I'm going to try lifestyle. And if you get it elevated, then I need to treat this patient and I cannot just leave them be there. Yeah. So, hyperlipidemia is a complex issue. We think the guidelines is easy and you just go by the guidelines, but there's always these things that are in between that you do not know exactly what to do with. I think we covered most of the questions over here. So maybe I'll take, if anyone from the audience have any burning questions, just feel free to post them and I will ask, yeah.
Yeah, I was going to ask you, since you are an imaging expert, Doctora, what about the carotid intermediate? Or ankle brachial, these other things to use it to risk stratify the patient. How do you use that?
So you can use them in the place of calcium score. So they're always for intermediate risk patients. So you're trying to classify them, to a high risk by using these, these parameters, and you can ask for them. Ankle brachial index can be done in the clinic, although we're too lazy to do that.
Yes.
It's easier to send them to the vascular clinic to have it done than to actually do it, but it's doable.
Yeah, so they call it the window to the heart, really. We are not underusing these things. But I think it's very important, as you say, very cheap as well. Yeah.
It's a cheap assessment, and once you have it abnormal, this is a patient that's no longer intermediate risk. So you need to treat this patient. He has a vascular problem. He's now high risk. So it's very important to think about these risk modifiers, right? Not to overlook them. So a good question. So when do you stop treating hyperlipidemia?
Endless. You don't stop. Unless they contraindication or side effects, you mean? If there's no side effects, no, it's a lifelong until something happens.
Yeah, I think maybe I think they may be asking about what's happened in real life. We have patients who are coming to us with a really serious side effects from the statin. Here you need to give a break. And that depends on how high level is the CK or the liver enzyme. And then you give a certain time of break per guideline, says 6 weeks. Some say, it's different. Then you re-challenge that. Then sometimes patient not tolerate the statin. You need to say, "Alas, you're not able to take the statin. Here you need to try the other means of lowering the lipids." But again, not to forget the diet, not to forget the physical activities. There are play roles, although the people the other day I was listening to some expert who don't like the ketone diet. They say ketone diet increases your LDL, and they try to give examples from different studies. But again, it depends which study you look at. There are patients who they did ketone and LDL gone down. So we have to be really fair with what we see, and it should not take one study and forget the others. I think by any things the patient able to do, reducing their weight, mentally, physically, diet, all these are very helpful. In addition to be adherent to the therapy, which has got a real benefit, and we know the statin among them.
And we shouldn't also forget about bariatric surgery. Some patients, they're just not going to achieve it with with lifestyle modification. That this is not going to happen. And I think it's fair game to, especially if you have a high risk patient who's morbidly obese, to send them for bariatric surgery. That can affect their lipid parameters significantly.
Yeah, you see, Dr. Jawahri, I think bariatric surgery and this is prove that losing weight is important. Does it? You can do it. I know certain people who are in their family, the members had bariatric surgery, and he mentally had it. No, he didn't have it, but he mentally said, "Look, I had a bariatric surgery." So he became like them, thin. So you need to stop eating too much and be active. And that's really helpful. You don't need to, because depression is the problem. Because depression is the problem, Doctora. What happened to these people, bariatric? Look what happened to them. Wallahi, I don't want to go into that area, but it's not the way. It's not the way. Maybe the surgeon maybe don't like me, but this is the truth.
They get lots of nutritional deficiencies. It's true, and we see them sometimes with lots of non-specific cardiac complaints afterward. Palpitations, feeling unwell. But I think some people, this is their only, if someone is, I saw someone in the clinic today, no cardiac issue, but he's really wheelchair bound because he is morbidly obese. And the man is only 40 something, haram. Yeah. And he's on psychiatric medication, so the psychiatric medication makes him eat. So he's not in control of this. So maybe certain people would benefit from that. And he has diabetes, he has OSA, he has everything except cardiac disease. That's the only thing that's working. So.
Yeah, I have many examples. Actually, a patient who had lots of comorbidities, had MI, stent, diabetic, dyslipidemic, chair bound, as you said. And then when they had this gastric sleeve or bypass, so really they changed remarkably. But I'm saying this should not be the norm. It's become more of a doctor. It's become like a fashion nowadays.
It's the fashion. So I think so they sent a clarification about that case with so it was a mixed hypertriglyceridemia and hypercholesteremia, the patient who had pancreatitis and she was pregnant, and she was actually asking if instead of terminating the pregnancy, would plasmapheresis help in that case? I mean, I doubt it because, she had pancreatitis. Plasmapheresis is going to take some time to work, and there already pancreatitis happened. So I don't think that would have saved pregnancy. I don't know. What do you think?
No, I agree.
Yeah.
I agree.
think she would have been, she would have needed termination either way. Yeah.
Yes.
Okay, that was very enjoyable. The discussion with you two. No matter how many times we talk about hyperlipidemia, there's always more fun things coming up. So I'd like to thank you, Dr. Abdullah, and I'd like to thank you, Dr. Antoine. It was my pleasure to have this discussion with you two. And
thank you so much.
We look forward to having more and more meetings. Do you have any last messages for the audience? Dr. Abdullah, maybe you can go first.
Yeah, please, for audience, you are the listeners, you are expert in your field. We are really, just exchanging ideas together. We're always looking forward to see you in another events. And please, as Dr. Al-Juwairia said, please send your feedback so we can, tailor the sessions, the education towards the needs of everyone. Thank you very much for being with us.
Dr. Antoine, any last words?
Thank you for inviting us, and thank you for having this wonderful evening with you all. For the colleagues, I would say be more firm in treating hyperlipidemia with your patient, because patients tend to be always resistant to therapy, to taking new pills and new tablets.
Excuse me.
So really you have to, and hit hard from the beginning. So I've seen many patients and many doctors starting their patient on very low dose, let's say 5 milligram and then 10, and then it takes forever. No, just, we know you have a target, you need to reach it, just hit it from the beginning. So that's why the point of, for example, of this discussion this evening is just to use the combination. Combination has been proven, not only rosuvastatin ezetimibe, even atorvastatin ezetimibe. They both are, just to be scientific and be academic. So really the combination, either or of these two combinations available in the market, use them. I have now more and more patients on combination right from the beginning, honestly. So just, hit hard, don't wait, don't waste time. The patient's going to take the medicine. So they don't know really much about it, whether it's 10 or 20. Use 20 milligram, for example, let's say of atorvastatin, or right away 10 or 20 milligram of rosuvastatin. Then they will take it. But if you start with 5 and every time you want to add, they feel, oh, my condition is getting really worse. And I know the doctor is adding more medicine. I need to see another doctor now because maybe give me something else. So start her from the beginning. And then I think you cut it short and you get to your target quick and easy.
Thank you both. And I'd like to remind the audience again to answer the survey and the questions so you can get the CME point. And thank you, everybody, and have a good night.
Good night. Thank you. Thank you, Dr. Abdullah. Thank you, Dr. Juwairiya. Thank you all for the organization as well. Thank you very much. Good evening.
Good night.